Okay, this is our ICM review of chest imaging, and we'll start off here looking how imaging looked in 1964. These fellows look pretty excited here. They're checking out their x-ray. They got their phone ready for any emergency calls. So let's see what we've got. Okay, so basically x-ray, we're going to talk about that. That's a great initial study. Why is that? Well, portable ICU, you see that it's great for post-operative patients, and we can assess vascular and ventilation status, and we can drive some of our interventions. What kind of exams do we get? Well, the standard is the PA and lateral. This PA stands for posterior to anterior. It's the direction the x-rays travel. So we have a frontal view and a lateral view, and we see things rather well. We realize that there are certain areas that we can't see very well. We can't see this area very well behind the heart on the frontal view, and that's where the lateral helps us. And we can't see this area behind the sternum very well on the frontal, and that's again where the lateral helps us. We've got portable x-rays that we can get when people are in the ICU and can't come downstairs. There's an advantage to that. They don't have to travel. The disadvantage is things don't look quite the same because the x-ray travels from anterior to posterior. It's called an AP exam, and the heart can look a little bit bigger and the lungs can look a little bit more congested a lot of times. So what else can be a problem? Well, with someone lying down, you can't tell as much about how fluid is collecting in the chest, and it can layer out posteriorly and dependently. Here we can see a very large pleural effusion collecting, and we might not appreciate that so much on just the plain radiograph. Well, what else can we see? Well, we can turn the person sideways. Another exam we can get is a decubitus chest x-ray. Turning the person on their side, the decubitus view is described by the dependent side. We can see fluid layering there, so there's an exam we can also get in addition to the PA and the AP. We can also at times angle the x-ray so we might be able to see the apices a little bit better, an apical lordotic view. We don't do that as much now that we have CT scan, but sometimes this apical region right here is a little bit difficult to visualize due to the overlying clavicle and the ribs. What else can we do? Well, we can inject contrast into the pulmonary artery, and we can look for pulmonary clots or filling defects. Pulmonary arteriogram, not done as often now that CT scans are really much better. This involves a catheter traveling through the heart, through the right atrium, right ventricle into the pulmonary arteries, and really the CT scans are done more to evaluate for pulmonary embolus, but it is an exam we can do, a pulmonary arteriogram. We can also have our friend drink some barium. It'll outline the esophagus. We can see how the esophagus looks and if there's any mass or anything pushing on the esophagus. So those are kind of the ways we can use the plain x-ray, but the plain x-ray has some limitations, and we'll talk about these a little bit. Inspiration, the overall exposure or the density of the x-ray, and then somewhat about the positioning of the patient. Inspiration, here the same patients taking a big breath and a small breath, and we can see how many more ribs we see and how the lung looks really well expanded on the image to the left, and on the right looks like a very poor inspiration, and we might think the person has some heart failure, but really it's just the inspiration. What else happens? Well, we're not going to see the lung fields as well on an exam that is somewhat more penetrated or is blacker or does not have as much density on the x-ray, so these areas of the lungs might not be seen as well, and the area behind the heart won't be seen as well. Behind the heart it will be too white. Up in the lungs it would be too dark, and we might miss things. So see, as an example right here, here's the same patient, one x-ray. It's a little bit hard to see, but there is actually a pulmonary nodule right there overlying that rib, and that x-ray is a little bit darker, harder to see, and here's that nodule. So that's how that overexposed or overpenetrated x-ray could be harder to see. The patient can be turned if they're rotated. Now these are two different patients, but you can see how the mediastinum is much distorted when the person is rotated. The clavicles are at an angle, so rotation can distort anatomy, and we talked a little bit about that lordotic view, good for looking at the apices, but it makes the ribs look more horizontal, and it can make the anatomy a little bit more peculiar, so angulation sometimes can be a problem when it's not intentional. That kind of summarizes what we get with x-ray. One of our modalities, certainly a great one to use initially. CT scanning is a great one for follow-up. It's a really major modality for problem solving, great for evaluation for pulmonary embolus and malignancy staging, and really is a go-to imaging study for trauma, also directs some of the interventions. So what can we tell? Well, from this x-ray we can see all these rounded areas overlying the lungs here. The CT scan, able to see a little bit better, able to see the lungs. We're able to better characterize findings in the lungs with the CT scan, looking at images with the lung windows, and we can look at it with also soft tissue windows. So here we're seeing this large mass in the AP window or in the left hilum impinging on the recurrent laryngeal nerve. So looking at that mass, we can certainly get a better approximation of its size. And so going on, well, images can also evaluate the spine. Here's an unfortunate person, metastatic disease in the spine, and we can see that involvement there on the CT scan much better. And we can see those questions about pulmonary embolus. Here's the normal main pulmonary artery and the right and left pulmonary arteries. And here we're seeing these large filling defects. These are clots from typically from veins that have spread into the lungs, blocking the pulmonary arterial flow. Well seen here with this CT scan or CT angiogram. And so that kind of summarizes mostly what we can get with CT scan. Magnetic resonance, another choice, probably not used as much, maybe more problem solving if we can't figure out things with the CT scan. We can get a sort of an arteriogram type effect, and we can use it sometimes for staging for malignancy. Here's our friend here, has this area of asymmetry. This left apex has got much more soft tissue density compared with the right, and that area can be a little bit harder to see with CT scan, and here the MR scan can show that tumor, that malignancy affecting there, the so-called Pankos tumor with associated Horner syndrome. And the MR scan is very good for evaluating those apical lesions because we can see the spine and the neural involvement a lot better. So especially up in there, MR scans. We can also inject some gadolinium contrast. We talked about that in the initial series here, but here we're seeing the aorta outlined. We can get that with an MR scan. And again, we can look at the spine, sort of like we did with the CT scan, but with the MR scan, we can see that involvement better. We can see the cord, and we can see this metastatic lesion here impinging posteriorly on the cord. Again, that view on the plain X-ray. So MR scan, more of a secondary tool, more problem solving. Nuclear medicine, one also to think about. What can we do there? Well, probably more for malignancy staging as well as evaluating for pulmonary embolus. And so where would we see that? Well, especially with that PET scan, that positron emission tomography scan. Here we're seeing this lesion with this increased metabolic activity, very worrisome for a lesion, and we could we could evaluate the entire body to see if there are any other lesions. So malignancy staging and lung scan, well, we can inject a radioisotope as well as have the patient breathe some in, and we can compare how the lungs look with ventilation and how they look with perfusion, because we would expect them to be the same. But in our friend here, unfortunately, we have this triangular defect in the periphery of the right lung on a perfusion scan, and it ventilates normally. So that would be very worrisome for a pulmonary embolus. So the so-called ventilation perfusion scan or VQ scan. Well, what else can we see? Well, we can evaluate the whole body and the skeleton as well. Here, we're seeing multiple metastatic lesions throughout the spine on that bone scan. Ultrasound, not really used as much. Pretty good, though, for evaluation of pleural effusions, and especially in the emergency setting, we can evaluate the volume status, evaluate the IVC and cardiac activities. We can direct some interventions, and in the ICU, the pulmonary folks can evaluate for small pneumothoraces at the bedside, something that radiology we don't do since we've got the X-ray handy, but there is a way to do that at the bedside. What might we see? Well, if we had a chest X-ray and we had this large area of density here with ultrasound, we could see, yes, there's a big large pleural effusion and some atelectatic lung there. And so that really summarizes our choices there. I think chest X-ray and CT scan are our major modalities, and then our other ones, MR, nuclear medicine, ultrasound, are probably secondary. So that kind of summarizes it. And so radiology, like everything else, is changing. We've gone from the analog world. Here we've got our dial-up phone here, and our three radiology guys. They look pretty snappy, but they're not smiling. Here's 1964, and now here's an image from an advertisement for the big radiology convention 2014. And look how happy we've got. We've now got women in the field, and they're dressed pretty snappy there as well. They're wearing scarves because they're in Chicago in November and it's pretty cold, but they're happy. They're looking at X-ray CT scans, and we've gone a long way here. So we, like everybody else in medicine, is evolving too.